Okay, good morning. Welcome. So I want to welcome you to the inaugural Philip Oyer Visiting Professorship. So Dr. Oyer is actually, believe it or not, about to go on a trip to Europe. I didn't know that he actually stepped on airplanes, and I certainly have never heard of him going to Europe, but apparently he's heading out to Europe today, and so he's getting ready, and it's a big deal for him. So he apologizes for not being able to join us today. In fact, when I first approached him about creating a visiting professorship to honor him, he thought about it, looked at me and said, okay, but only if you promise not to make me come. So I'm holding up to my promise. So Dr. Oyer, despite his gruff appearance and behavior, is a rather well-known and accomplished surgeon scientist. He came to Stanford in the 1970s and was very instrumental in the development of cardiac transplantation together with the entire Shumway team. He has great stories about the old days, and you should, if you get the chance, sit down with him and ask him about some of the early days. And Dr. Oyer really started doing research in artificial heart pumps. And down in the basement of Falk, you'll see in that large animal structure some infrastructure which tells a little bit about the history of some of the research they did there back in the 80s. But Dr. Oyer was the developer of LVAD bridge transplantation, and in fact performed the world's first successful LVAD bridge to heart transplant back in the early 80s, 1983. And obviously was involved in a lot of other developments. He led the heart transplant program, and was involved in lung transplants and heart-lung transplants, LVADs, and he even did type A dissections, among other things, and served as our interim chair in 2012 and 2013. Dr. Oyer has made immense contributions to our entire field, and we are indebted to everything that he has taught all of us. So to honor Dr. Oyer, we thought about inviting someone who really represents all of that. That is surgery, science, cardiac surgery in general, heart failure, transplantation, LVADs. And we could think of no one better than Anelechi Anyanwu from Mount Sinai. Dr. Anyanwu is a close friend to all of us. He was educated and trained in Nigeria and in London, and served as the second to last fellow of Dr. Professor Magdi Yakub. So he has a long lineage in historical cardiothoracic surgery training. He is very skilled in complex valve repair, which we know Mount Sinai is very famous for, and also leads the transplantation and mechanical circulatory support program there at Mount Sinai. Dr. Anyanwu is notable for validating and actually becoming a big proponent of the new Stanford heart transplant technique. This is his term for it. We just call it beating heart transplantation, but he's actually taken it to another level. He seems to do it all the time, and I believe Dr. Gunther can validate this later, but might be doing more of these than us now. So we thank you very much for doing that and taking the field to another level. But Dr. Anyanwu has a lot of accomplishments in both clinical outcomes research and novel techniques of valve repair and transplantation, has hundreds of peer-reviewed publications. He serves on multiple committees and is very involved in the leadership of the AATS. We are very fortunate to welcome him here to teach us a little bit about history, a little bit about surgery, and some other perspectives. I know you have some opinions on a few things, and we're very interested in learning from you. So thank you very much for joining us.
Thank you. It's a privilege to be with you. This is the second time I've been to Stanford. The first time was about 30 years ago when I was at your stage. I just finished my residency in the UK, and I was applying for an AATS traveling fellowship, and I wanted to come here and work in the lab with Dr. Oyer and Dr. Robbins, but I didn't get the award, so I ended up at Mount Sinai. Anyway, talking about what we're here to talk about today, Dr. Oyer, when I got the invitation, I said, well, what are we going to talk about? I know about Dr. Oyer's work in mechanical support. So I said, I'll just go and take a look at PubMed and see what Dr. Oyer has done. Because I wanted to talk about outcome assessment in surgery. That was the title of my talk. And then I just went back. He was a resident in the early 70s. So the first paper that I saw was this paper, again, the median stenotomy. So at the time, a lot of patients in the 1960s that had valve replacements were coming back for reoperations. And it was so hard to get back in through the front, so surgeons would go to the left chest and they'll go to the right chest, looking for virgin territories. And Oyer and Shumway argued that the stenotomy was still better. It might be more difficult to do, but they said the problems like dealing with hemostasis and dissection could be overcome. And they actually listed and said what they do in their operation. They said they take out the wires and they saw the front of the sternum, they cut the back with scissors, they dissect scars underneath, and then they go into both lungs, and so on and so forth, and do the operation. And then when I read this, I said, this was written in 1974, 50 years ago, 51 years ago. I said, that's exactly what I do today. That what Shumway and Oyer were doing then is what we do today. And then they had only done 300 of these, but they said in those 300 that bleeding wasn't a problem. That obviously got into the right ventricle now and then, but they could deal with these problems, and that they hadn't had patients die from the fact that they were redo. They could die for other things, but not from the access. And then I read the next paper he wrote and the next paper he wrote. And I decided that for this talk, what I'm going to do is I'm just going to go through some of Oyer's publications over the last, since 1974 he started, and see what we can learn. And I know Joe said you want to see what I can teach you, but I realized I didn't come here to teach, but I came here to learn. But I'm going to share with you what I've learned from Phil Oyer and his history of publications. I don't have any disclosures. So the second paper I read was this one by Ed Stinson and Oyer. So they looked at 10 transplant patients. This is in early 1970s. Each patient, they put in a catheter in the pulmonary artery. There were no Swan-Ganz catheters back then. They weren't in wide usage in 1974. And then they would draw bloods to check the fixed cardiac output. And they demonstrated that when the patient came out of a heart transplant, the cardiac output was low. Usually they had an index in the high ones. And over 7 days, the index got better because the stroke volume got better. So that's the first thing. So the transplanted heart, it doesn't, function adequately straight away. But then they checked the effect of both atrial pacing and ventricular pacing. And you can see ventricular pacing on the left, the heart rate went up, but the stroke volume went down, and the cardiac output went down because the stroke volume went down. Whereas with atrial pacing, there was some reduction in the stroke volume, but not as much, and that was compensated for by a high heart rate. And they found that the best cardiac output was when you paced at 120 as opposed to 100 or 80 or 90. And that's where the practice came, and it went into textbooks that heart transplant patients were paced at 120. That's from this little experiment with 10 patients. Obviously, isoprenaline, or isoproterenol is called here, did better because it also increased the cardiac output. So isoproterenol became the standard inotrope for many years, and it's all based on this work of 10 patients. But the lesson learned, though, applies to every patient till this day, that heart rate augmentation by ventricular pacing produces no improvement in cardiac output because it decreases stroke volume. So if you want to increase cardiac output, you atrially pace. The other thing, of course, that they learned is that even though at the time you cut open the left atrium, cut open the right atrium to do the traditional biatrial anastomosis, still you preserved atrial function. Then the next is a series of valve papers we're going to go into. So this was written by Oyer in 1977. At Stanford, they were doing a lot of biological valves, and this is the first series they published on the Hancock prosthesis. They included patients who had both the mitral valve and the aortic valve replacements. And Their follow-up was quite strict in that they actually called patients. So they actually called either the patient or their doctors to see whether they were alive and what was happening with them. And essentially what they demonstrated when they compared the Starr-Edwards, which was more or less the standard, with the Hancock, was that the Hancock did better in terms of survival, but most importantly in terms of freedom from thromboembolism. So the thromboembolic rate was much less with the Hancock valve. And they said that although it was less, it wasn't eliminated. So some patients with the Hancock valve still got thromboembolism. And on that basis, they recommended anticoagulation for 3 months. So this is where all that came from, that for the first 3 months with the bioprosthetic valve, you should be anticoagulated. So those were the initial signals, but the initial signals were that the Hancock valve did better than the Starr-Edwards valve. And they stressed then, which remains true to this day, that when you consider the merits of various prosthetic valves, you have to always consider the requirement for anticoagulation therapy. And really, they said that that often we ignore that and focus on survival, but we have to consider the time and inconvenience that patients require for long-term anticoagulation. So this they were saying in 1977. The next paper goes to the ventricular assist device, which is what Oyer is most known for. So this is the first paper that he wrote describing what would then become the Novacor device, which was an electrical pump. So at the time, the NIH was pouring a lot of money into artificial hearts, and most people were focused on pneumatic devices that will pump air into a device, and it will just pump it, and the air will shift the plate and move the blood. Oyer was partnering with an English engineer called Pierre Portner, who was working in this Bay Area and had a lab and was developing artificial hearts. And they were trying to develop an electrical heart, so where you could transform an electrical signal into a mechanical force that would drive the blood as opposed to pneumatic, and that's what they designed. And it was very complex design with multiple components at the time, but they tested this pump, which they had made in various cows. I'm sure it's somewhere in this campus where they did these experiments. And they were found that they were able to keep these cows alive for weeks on this new pump that they had. And but the key things though, that this study is really what opened mechanical support to what we know today, because they were able to prove a lot of concepts in these series of animal experiments. They could show that it was possible to have an electrical pump in an animal that works. They showed that it could keep the animals alive for a long period of time, and there was no mechanical failure. The longest period was about 3 or 4 months in this experiment. They confirmed that on various kind of physiological and pathological stresses, these pumps still kept the animals alive. The animals still would grow because these were young calves. They still grew to adults despite that. And they showed that they were able to define certain things, like, for example, it's better to have the device as an assist device working in synchrony with the left ventricle and not competing with it. And really, this is what actually set the stage for where we are now in terms of that it's actually possible to keep an animal or human alive with an artificial device, and they can grow and function normally. The next paper is a paper on ventricular aneurysms. So they looked at 170 patients who had their ventricular aneurysm repair at Stanford between 1970 and 77. And they made this observation, simple observation, but very important. If you had heart failure as your presenting symptom, you did worse than if you had angina. Obviously now it seems very obvious, but at the time it didn't. And really this has set the stage for what we call it viability and by other signs. But more importantly, they looked at the ventriculograms at the time, and this is just a CNA ventriculogram, and they were able to look at the function of the residual heart, and if they felt there was sufficient function or not sufficient function. And that's what they call contractile reserve. And they found that patients with contractile reserve did much better. And they said then that whatever method you use to determine contractile reserve, if you have it, you do better with aneurysm surgery. And that really is the basis of, they said this relationship is consistent with any treatment for ischemic heart disease, regardless of whether you're going to resect the ventricle or not. If you have contractile reserve, you do better. So this is back in 1979. Patients were not having echocardiograms then. So it was all done based on ventriculography. And then we enter another study, which is now broadening into aortic valve replacement with coronary bypass surgery. And this is written by Craig Millers, now at Stanford, and did this study. And basically, they wanted to see, does coronary bypass surgery make a difference if you do with aortic valve replacement? But the key things I found about this study is it introduced a new way of doing surgical research, which is things that you have to document. So patients have to be followed up, personal communication. You have to say the closing interval when you stopped following up the patient. You have to declare how many patients were lost to follow up. So all this is before consult. This is in the 1970s when medical surgical research was everywhere. You have to say the follow-up period. In this case, the average 19 months. Without knowing the average follow-up period, you can't really follow what you're doing. You have to talk about operative deaths. At the same time, at that time, many series would not consider you as an operative death if you died like 2 weeks later at home. And you also have to include deaths regardless of the cause. Because at the time, let's say you had heart surgery, and then 3 weeks later you were hit by a truck because you were, a big giddy crossing the road. That's not a cardiac death. You wouldn't feature in the studies, but it's now all-cause mortality. I think this paper really set the stage for modern outcome reporting in surgery. It didn't actually find what it was seeking to find, in that whether you had bypass surgery or didn't have bypass surgery, your mortality was the same. It didn't change. But what this study did show, though, is that they had looked at patients who had angiograms. So some patients had angiograms before surgery, some didn't. And they tried to correlate it with the presence of angina. So if you had chest pain or you didn't have chest pain, and they found that they couldn't really tell whether a patient had coronary disease from whether there was chest pain or no chest pain. And they found that depending on the age, like if you were 30 to 40, there was a 20% chance of having a positive angio. And as you crossed the threshold of 40, got closer to 80, there was a high incidence of coronary artery disease. And this is where, if you look at the earlier iterations of the guidelines, recommending angiography for patients above the age of 40, this is the paper that was referenced for that. Then continuing on the issue of bioprosthesis. So this is the next paper by Oyer on long-term evaluation of the porcine prosthesis. Obviously, it's not long-term, but at that time, it was thought to be long-term. But they now introduced a new concept of valve failure, because then the literature was all over the place. People were writing whatever they wanted to write, how they wanted to write it. There was no standardization. So they called valve failure four things. Either you have a new murmur. Remember, there was not much echo that day, in those days. You had thrombosis of the valve presenting clinically. You had infective endocarditis, or there was confirmed hemodynamic dysfunction that required a reoperation. So this was valve dysfunction. And they also introduced a new concept called intrinsic stenosis. Now we call that patient prosthesis mismatch because we understand it more, but they recognized that there were some patients that had valve dysfunction and they took out the valve is entirely normal, but the patient did have valve stenosis, and they call that intrinsic stenosis. So they looked at the outcomes of a mitral valve, aortic valve, and double valve replacement. Of course, high operative mortality. A lot of the patients died within 7 or 8 years, which was what was expected. But in terms of thromboembolism and freedom from valve-related complications, it was very low. So at 5 years, less than 10% of patients were reoperated. So the valve failure rate was very low. So because of that, they were encouraged, and they felt that, the xenografts were the way to go, that there's no tendency towards increasing failure deaths by 7.5 years follow-up. So the signals were good. And at the time in Stanford, they were moving more and more away from the mechanical valves. Leaving the valves and just going to dissection. This is a paper, on another paper written by Dr. Miller and Oyer and others. So they looked at patients who had dissections at Stanford from 1963 to 79. And they stressed again the Stanford classification, which had been described in the early 70s, but was not widely adopted. So it's a type A if you have involved the ascending aorta, regardless of where the tear is in place. And they gave the big rationale as to why this was a better classification than other classifications, which a lot of other surgeons at the time did not accept. But the other thing that they did say is that they said that they operated on every patient regardless of the presentation. Anson was telling me he did a 101-year-old patient last week. I don't know that they did that in the 70s, but what they did do, if you look at their age range, the oldest patient operated in this series was 86. And these were patients operated on in the late 60s and early 70s. So it's true to their talk that people coming to Stanford at the time were getting aortic dissection surgery. And many of them had either tamponade or myocardial infarction or aortic incompetence. So these were very sick patients. And of course, the outcomes were not great. About 20% were still alive 10 years later. So it wasn't really that great outcome. But many of these patients at the time, they were not doing circulatory arrest. So about a fifth of the patients, the intimal tear was not resected, and they couldn't find any difference in outcome whether you resected the intimal tear or not. So they said, well, it doesn't really matter whether you resect the intimal tear in those patients. And obviously, this was one of the biggest series at the time, but it's interesting that when Dr. Miller presented it, he said that he would preface his comments by stating, we haven't found the ideal solution. So we still don't know, and we're still learning. And we continue to learn till this day, but it's that humility that despite the expertise, they're saying, well, this is not the end of the story. And as you see, as we go along, it wasn't the end of the story. The next paper I'll mention just briefly was the work Oyer did with the radiologists with CT scans. CT scans that just came out, and they were using CT scans to look for graft patents in coronary bypass in 1980. And they showed that you can show proximal occlusions of vein grafts with this. And they proposed at the time that if you can find a way of gating this to the EKG, you would manage to get distal resolution of the bypass grafts as well. And of course, that didn't happen then, but it happened a few decades later, and now it's become standard of care. So going back to the Novacor story. So we're now in 1980, and Oyer has written this paper on trying to transform this technology to human beings, and this is how it's going to look. So you're going to have this pump that's going to line the abdominal cavity and connected to the descending aorta, supraciliac aorta. It's fully implantable. You have a transcutaneous transfer going on at the waist. And he defined the three components of an electrically driven assist device, which apply to every pump today. So there are three things. The first is an actuator. You have to convert the electrical energy to mechanical energy. He did this through a magnetic solenoid at the time, and then it just releases a spring, and then it just keeps pumping. So it was a pulse style pump, but you have to find a way to transfer the energy. The second thing is you need a pump. So you need a pump that's actually going to move the blood. So the mechanical energy goes to the pump transfers the blood. So that they had done. And then you need a way of transmitting the energy system. And at the time, the Novacor, they were working on a completely implantable system, as I said, with a coil inside, implantable battery, and transcutaneous energy transfer, which they had done in dogs. And they tested this model in the animal, and it certainly worked. And they were able to show that the hemodynamic performance. And a lot of the things that we take today for granted, they demonstrated, for example, that you get good reduction in the left ventricular pressure if it's synchronized with the heart rate. If it's not synchronized, you get reduced LV pressure, but not as much. And obviously, if you switch the pump off, the LV pressure goes up. So these are things that we VAD surgeons take for granted now, but it was all designed then. And of course, they said that conceptually, that there's some considerations that transforming this technology to man requires. They said and remember, this hadn't been done in man at this time, so they didn't know. But he said that the unpredictability of the time function of patients with potentially reversible disease mandates an option for either short or long-term support. In other words, when you put the pump in, you don't know how long the pump is going to be there. So you must have an option that gives the patient the chance to either be a short-term support or long support. He says that it has to be a pump that will not jeopardize procedures downstream. So whether it's going to be removed, it has to be removed with minimal trauma. If the patient is going to have a transplant, it has to be transplantable with minimal trauma. So, and he said that none of these could be satisfied with a pneumatic pump, that an electrical pump had to satisfy this. And he predicted that there will be thousands of patients who need this technology. Indeed, at Stanford, based on the amount of patients being seen at Stanford, he said that you should be doing 300 a year. Is that how much you're doing now? 300 a year? I don't know, but that's what he said in 1980, that it should be 300 patients. The next paper was quite interesting. It was a collaboration with Oyer and Rice did with William Kolb's lab. I think it was in Salt Lake City, on artificial hearts. So because then nobody knew what would happen when these technologies were transformed from animals to man. And the question was, well, if you did a total artificial heart, you put it in and a heart came and you took it out, and could you actually do that operation and would it work? So they used a clever design. They got some homozygous twins that were calves. So they're two calves. One of them gets a total heart, the other one they're allowed to grow. 6 months later, they sacrifice the one that's not transplanted, take the heart out and do the transplant, take the artificial heart out and do the transplant. And they were able to find in a series of calf twins that they could actually do this operation, that you could take out a total artificial heart and put in a transplant, and the transplanted heart will survive. There's no need for immunosuppression because they're twins. And now it seems very intuitive to us, but it took a long way to get there. So we're now in 1982, and this is a paper on cardiac transplantation, a perspective on the future. So Stanford had been doing transplants. Back in 1982, there were 4 hospitals in the world doing heart transplants. There was here, there was Richard Lauer, I think he was in Virginia, Christian Barnard, and then La Pitié in France. Those were the only places. So Stanford, kept going. And they presented their data for 267 transplants, and this was their 1-year survival. And they showed that in the most recent cohort, done in the preceding 5 years, that got their 1-year survival to 77% from 29%. But most importantly, what they showed is that for patients who were listed and never got a heart, practically none of them survived 6 months. So they said that based on this, there's no doubt that heart transplant works and the therapeutic efficacy is not disputable. So this was in 1980. This was presented at the AATS. And this was the paper that led to surgeons to start thinking of going back to heart transplantation. And they also showed that the patients did well. There was no, most of the survivors were in class 1, NYHA. And they looked at the causes of death, and they found then what remains true till this day, that at any given time after transplant, you're more likely to die from infection than you are of rejection. Infection is the biggest cause of death, and it remains so in the early, middle, and late phase. And they showed this back in the 1980s. So after this, a lot of people say, well, it was cyclosporin that led to the success of heart transplantation. And that's really, if you don't read the history, you'll get that, you'll think so, but if you read the history, you find that's not the case. Because in this paper, cyclosporin was introduced a year before, and there were only 9 patients of the 267 had received cyclosporin. So it wasn't cyclosporin that drove their outcomes. It was years of evolving patient management protocol, being able to manage rejection, manage the patients, and so on and so forth. So the cyclosporin was a good thing, but where cyclosporin did make a difference was in this next paper, which is on heart-lung transplantation by Bruce Wright and colleagues. Because at the time, no one had succeeded in transplanting the lung, whether part of the heart lung, single lung, double lung, anything, they all died and died within a month, either rejection, bronchus broke down, infection, they couldn't get it. But cyclosporin changed that, and they reported on 3 patients that they did heart-lung transplants and talked about the immunosuppression regime. The first patient was home within 3 months. The second patient was home within 60 days. Very good results. But what's interesting, this paper was published in 1982. The operations were done in 1981. They didn't rush to the press and rush to publish when they had the first case or the second case. They waited for the third case. And the third case is even more interesting because the third case was a patient with transposition who had had a BAFS procedure. So they, put the IVC homograph to the left atrium and then had a mustard after that. And they did a heart-lung transplant on this patient. Obviously, it was a very tough operation, bleeding everywhere. The patient came out of the operation in a bad way, died a few days later. And then you ask yourself, why would they, reporting the first heart-lung transplant in the world, add a third case, a patient that died? Who does that? Nobody would do that now. You just publish your first case, you go to the media, you get a new contract, you become a celebrity. Nobody would add a failure. But they did that, and they even commented that the death of this third patient showed that maybe we shouldn't be doing this operation in someone with previous cardiac surgery and so complicated that they probably shouldn't have done. And they criticized themselves and said, well, we should have just removed this homograft in the first place and just reconstructed the IVC. They were able to self-criticize, and that's something that's really lacking in our literature these days. And then the next paper, this one is coming back to the Nova course. So this is now 1983. So they're now Oyer is now trying to tell us we're ready to do this in man. So this is what we're doing in human beings. So now they've now put the whole pump together. So what was very experimental in the animals and sometimes in different parts in the animal is now in one unit. So you have one unit that contains the energy converter, the actuator, and contains a blood pump. And then the electrical transmission system is going to be outside the body. And they demonstrated that they could keep these animals alive. And the most recent iteration seemed to work very well and could keep the animals alive for 3 months. And they felt it was now ready for trialing in humans. So that was 1983. So back to the valve story. So this is a paper on the 10 to 15-year assessment of the Starr-Edwards valve. So the Starr-Edwards valve was standard. This is 1983. That was the valve to use, and everybody used it. So Craig Miller presented this study at the AATS that year to look at the outcomes. And when you looked at the outcomes of Starr-Edwards in the mitral position, at 10 years, 80% of patients had valve failure. It's either the valve had failed, they had bled, had major bleeding, thromboembolism, or they died. 20% success. So he presented this data, and the other thing that was important from this data, and this holds true to today, is that if you have a valve-related complication with a mechanical valve, your mortality rate was high. So if you had thromboembolism, about half the patients died. If you were reoperated because of a valve thrombosis, about 70% of the patients died. And they said, well, for the porcine valves, the ones we operated on, only about 7% died, because there was a big difference in the urgency of the operation and how sick the patient was if a mechanical valve failed and if a tissue valve failed. So the summary was very strong. So it says, few, if any, cardiologists or surgeons can view these results as optimal, even considering the remote era of operation, even though some of these patients operated in the 60s. So hence, structural durability alone should not be what makes us decide for valves, because these valves last forever. You can put a Starr-Edwards valve or a St. Jude valve in a machine, it will pump for the next 20 years, it will never break. So valve failure being responsible for 22% of early and 27% of all late deaths is unacceptable in our opinion. So this was probably the president at the AATS. Obviously, none of us were there except Dr. Miller, but you can tell people were very angry when they heard this. So this is Albert Starr himself. And Starr basically says, my valve failure rate is not like that. I have 90% whatever success rate. And then he brings up a valve that Shumway used in the 60s when he was putting homografts in the mitral position on a stent. I said, well, you did that and 40% of them failed. So who are you to say that my valve doesn't work? So that's Starr. Björk, who is a famous surgeon from Sweden, says, well, I don't know what you guys do, but in Sweden, anticoagulation is less dangerous in Sweden. So you get it. And then the Mayo Clinic takes it to another level and says, you're missing the point. It's not the valve, it's the patient. The reason these patients are doing poorly is because of the mitral valve disease. They have atrial fibrillation and they're dying from the valve disease. They're not dying from the valve. So you can imagine how controversial this would have been then, because it was challenging what was seen as the norm. But a year later, they presented the same data, this time with the aortic valve, a bit better than mitral, but still half the patients in 10 years had a valve-related event. And they showed the same thing, that if you did have a valve-related event and had to be reoperated, your mortality rate was very high. So exactly the same scenario. And that they said that even if we argue that anticoagulation is better today than yesterday, that doesn't necessarily transform to it being better for patient outcome, and that still applies till this day. So going back to the Hancock valve itself, so they keep publishing these. So now they're up to about 7 years. And at 7 years, they're now starting to see a drop off. So they're now starting to see these tissue valves are failing. So that you can see that the durability for both aortic and mitral is now going down. And they noted for the first time that if you had a mitral valve, the structural valve degeneration was more accelerated than in aortic valve. So this was the first publication they made that pointed that out. And they also found the intrinsic stenosis, which is this patient prosthesis mismatch, was more a phenomenon with aortic valve than mitral valve. So they accepted that there was degeneration, but they noted that those failures that occurred had not been catastrophic. And in the absence of endocarditis, they could usually be managed in an elective fashion. So that was a big difference between failure of the tissue valves and failure of the mechanical valves. So going back to the aorta now, we have Bill First is now at Stanford. And he looks back at patients who have had cerebral perfusion. So we all talk about cerebral perfusion, antegrade cerebral, as if it's something new. But they were doing it in Stanford since 1970. So they cannulate the innominate artery, the brachiocephalic artery, with a 14 French cannula, cannulate the femoral artery, go on bypass, cool the patient moderately to like 28, open the aorta, put a balloon in the descending aorta, and then perfuse the body, perfuse the head. That's what they did. They did it in 10 patients, and of the 10 patients, 7 of the patients survived. And they were able to do total artery replacements this way. And they presented the argument for doing it in these patients, which are the things we know today, and basically said that you were able to perfuse the brain. And the main advantage was that if the operation took longer than you planned, either necessarily or inadvertently, you had that safety margin. And they, of course, presented the arguments against hypothermic circulatory arrest and suggested that this is something that doctors should revisit. And this was in 1986. And this paper probably was read by a few people because it took at least another 10 years before antegrade cerebral perfusion became more widely used. So going back to the Novacor story. So now we're in 1988, and we see this publication, Isolated Left Ventricular Assist as Bridge to Cardiac Transplantation. Project 1988, Von Stans is the first author. And then you read the paper and you say, well, the first clinical implant of the Novacor was performed in 1984. But this paper is in 1988. They didn't report this for 4 years. People knew it had happened. It wasn't reported. I don't even know if Stans was actually at Stanford when he was there. But Oyer, who did, when the operation took place, but Oyer, who did the operation, is not even the first author. Neither is he the last. He has one of his residents write the paper and just describe this operation. So they've put in the Novacor device. They're now putting it in the ascending aorta. They tried doing one in the supraceliac, but subsequently did it in the ascending aorta. It's a tethered device connected to a big console at the time. And they did 6 patients. And what's to note is that all these 6 patients, they were supported for less than 3 weeks, short period of time, but 3 of them survived the transplant and then 3 did not. So that was actually a phenomenal result because it was the first time ever that the patient was successfully bridged to transplant with a mechanical device. It had been tried in the past, but the transplant never succeeded. And indeed, the first patient who was bridged survived 20 years after that. So they made several observations based on this experience in 6 patients. The first observation was that the pump was mechanically reliable with minimal need for adjustment. So regardless of what happened to the patient walked, the patient slept, the patient ate, whatever, they didn't need to make adjustments. So which was good. You had something that could just work automatically. The second is that the most dreaded complication, embolic events, has not occurred in any patient. So obviously they were wrong. And the mistake, which you residents have to learn from this when you're doing an experiment, is you have to choose your endpoint and measure it at the right time. these patients were just supported for a week or 2 weeks. They didn't support them long enough to know whether or not there was truly an embolic risk, but they drew the conclusion that there wasn't. And the third is that device removal is straightforward and heart transplant can be performed without technical difficulties. Again, another mistake because they took out the pumps within a week or two. But for those who do heart transplants here or whoever operated on a Novacore device, which been there for 6 months or 12 months, you know that that's one of the most difficult operations you can do in heart surgery. So you can't make the assessment based on partial information. But nevertheless, they said it was a great advance and a low risk of embolization, but that the next step will be to get a total implantable version of it. And they had a total implantable version, which if it's a pulsatile pump, you need to have like a capacitance chamber to collect the air inside. They had that. They had a battery inside, transcutaneous energy transfer, and they did it in animals back in 1989. So back to the heart transplant story. So now we're 8 years from 1980, where in 1980 when cyclosporin was introduced, and they presented this paper in 1989. So 8 years of cyclosporin treated patients, and they demonstrated better survival if you got cyclosporin compared to patients who didn't get cyclosporin. So that was good. And they also were able to broaden the recipient pool. So before, you would never transplant anyone more than 50, but now they went up to 60. They wouldn't take donors more than 35. Now they were going up to 50. So all this was possible with cyclosporin. But they said the key points are worth emphasis. The first point is survival. So they found that patients who were younger survived better if you were less than 50. The second was rejection. They found that rejection, despite cyclosporin, still occurred in 60% of patients. So it was very common, but it was often not fatal. Hypertension and renal dysfunction came into play. So most patients were found on cyclosporin were very hypertensive, and almost all of them had renal dysfunction over the years. Graft atherosclerosis remained common, and that wasn't influenced by cyclosporin. Neoplasms, lymphomas were common initially with higher dose cyclosporin, less common with lower dose cyclosporin. But the most important thing was rehabilitation. They said 85% of their patients were back to work. I don't know where they get patients from in Stanford, but like in New York, they don't go back to work, but they just stay on Social Security and for the rest of their life. But anyway, they're in class 1. So back to the Novacore. So we're now in 1991. Pat McCarthy is at Stanford, and they're predicting 20,000 patients a year for this Novacore device. That's what they're thinking. And they report on the experience from Stanford. Now they've done 13 cases. So 13 cases in, I think, 6 years. So not that many. And the bridge to transplant success, 70%. So of the 13, 9 patients survived the transplant. So that was truly amazing. And they're again talking about this total implantable device. And they say animal implants have been done at Stanford, and they're going to start clinical trials in 1992 of the total device. So as you see, that will never happen. So back to the porcine valve story, we're now 15 years out, and they now present their data, and it's becoming clearer that most bioprosthetic valves will fail after 10 years. And obviously, depending on the age group, they found that it's more accelerated if you're a younger age. So that we know. And then by 10 years, the intrinsic valve failure rate was 34% for the mitral. Sorry, freedom from valve failure was 34% for the mitral, about 20% for the 34 for the aortic, 20 for the mitral. Valve failure, freedom from valve failure. But of course, this is actuarial survival, so it doesn't tell you the truth. So they were not using a more reliable competing risk analysis. And there was a lot of conversation between the Stanford group and the Portland group about that over that time period, which if you're interested in history, you should read. But they said, regardless, the finite durability argues in favor of a mechanical valve. So the fact that the valves fail argue in favor of a mechanical valve. But other considerations have to be taken into account. And the most serious of these is the concern of a patient of having a permanent complication like an irreversible stroke from anticoagulation. And one cannot weigh put a value on that kind of anxiety patients have every day with a mechanical valve. So they still, despite this, said they will continue to use tissue valves at Stanford. So going to aortic dissections now. So they now looked at their 30-year experience. There's a paper looking at your 50-year experience, but that's more recent. This is 30 years. And they found that the patients survived better, but still at 10 years, about 70% had died, and at 15 years, about 80% had died. And a lot of them got reoperated, not as much as in the first series I showed you, but at 2 years, something like 40% had been reoperated. The operative mortality was about 20 to 30%. This hadn't changed. But what they did find is that if you were operated and you had no complications, as opposed to if you're operated with complications, the survival was different. So if you had no complications, so it means you have an aortic dissection, there's no malperfusion, no myocardial infarction, no aortic regurgitation, no tamponade, you did well. Operative mortality was 10%. But if you had those complications, then you didn't do well. So based on this came the recommendation that you need to operate on them early. You need to diagnose them early and operate early before these complications come. And if you do that, your mortality will be lower. The last paper on the Hancock valve was a 20-year experience, and that sort of summed everything up, and the valves almost always failed by the time it got to 20 years. And the younger patients, they failed quicker than others. That's all, you know, what we already know. So nothing really new there except to provide data that allowed people to stratify the patients more precisely. So back to the NovaCore story. So we're now 1999. So Robbins and Oyer write this paper, and now they've moved to discharging patients home with the NovaCore device. So they have a wearable version, and at this point in time, somewhere around 38% of patients were living out of hospital, so it was all good, all rosy. But it wasn't really all rosy, because one problem patients were getting and doctors were seeing was strokes. So remember how I said at the beginning that they said there was no stroke because patients were supported by for 2 weeks. But now as patients started getting to 6 months, they found that somewhere around 40% of patients experienced strokes. And when they took these devices out, they found a lot of craggy fibrin accumulating in the inflow. So they changed the inflow material. The stroke rate came down to about 20%, but it was still there. And it remained a problem and the main Achilles heel of this device. So the last paper Oyer wrote on the NovaCore was in 2001. So as I said, the strokes are there. They're over about, at this time, 1,700 implants. So a lot of implants around the world have been done. At Stanford, they're doing about 8 a year. That you can see there. They've worked in the lab. They've got the total implantable version in the lab, which has never come to clinical practice. And I don't know why, but it never did. So there must have been some problem with it. But what else has happened in 2001? The Nimbus device, HeartMate 2 device, has been implanted in 2000. The Jarvik device was implanted. So we now have two new devices which were developed in the early 80s that are now coming into play. But still, despite that, Robbins and Portner and Oyer still argue a case for the pulsatile pump. They're saying that the axial flow pumps are attractive because they're small, inexpensive, and simple to implant, but there are several issues. So they said that these pumps will create a non-physiologic state. There's no pulse. We don't know what the lack of a pulse is not going to do, and there's going to be a lot of shearing of blood, and that they said these pumps are not fail-safe because there are no valves. So when the pump stops, there's severe AI, the patients will die. So pump stoppage was bad. So there was this last ditch fight to salvage the NovaCore. And they talked of the next generation of NovaCore, which they were already working on this NovaCore too. But I think as events will turn out, the axial flow pumps turned out to be superior. Per Portner, who was the inventor of NovaCore, sadly passed away some years after this, and that also ended the Novoco, and then World Heart, which made Novoco, ended up winding up about 8-9 years later. So then the last paper about that I'm going to go through is this one on the hypothermic circulatory arrest. So somewhere around mid-90s, the Stanford group started using hypothermic circulatory arrest, PHCA, in that you can see the white bars there compared to non-hypothermic circulatory arrest. So prior to that, most of the aneurysms had been done closed with a clamp, and they started doing it without a clamp with hypothermic arrests. And they looked at the difference in outcome, and there was no difference. So despite the fact that the patients who were operated on with a clamp without hypothermic arrest were done in the 60s and 70s in an earlier time, they still had the same survival as those done under hypothermic arrest. They had the same reoperation rate. Everything was the same. And they did say overall it would appear that the patient substrate rather than the technique used is what determines outcome. But they said despite this, it doesn't take much effort. It's very strange. Even though they found that the study was totally negative, they still said they will continue to do circ arrest because they said that it doesn't take much effort and it should work. But then they suggested that you need future studies to work it out, that maybe the study was too small to pick up the numbers. So they continue to do circulatory arrest. So I've stopped there in terms of the Stanford papers. Shumway, as you know, passed away in the mid-2000s, and we're now into the more modern era of surgery. But why does any of this matter? So you would say, well, why am I talking about the history? We know the facts. We know that LVADs work. We know that tissue valves degenerate in X amount of years. We know that patients get valves. Why do I need to know the background? Why does this matter? I think this is a paper that was written over 100 years ago. And I think it's very important because it was written before any of what I'm talking about happened. This was written in 1904. So it was a doctor called Cordell in Hopkins who gave this lecture. And he was talking about the importance of the study of the history of medicine. And he says that by careful study of original authorities of manuscripts, we studying it have gotten as close as possible to the contemporary sources, that is to the events themselves. So like I'm reading all these papers, it's like I feel like I'm in Shumway's operating room or in his institution or in Oyer's lab, trying to understand what was happening at the time. And you cannot get that by just reading the facts. You can only get that by going back in history. And he goes on to say that it seems to be an imperative condition of our life and progress that we should be forever impressing on ourselves that there is no royal road to knowledge. There's no easy way to knowledge. And that he who wants to attain that hidden treasure must be satisfied to dig deep into the everlasting hills without any guide other than the uncertain chart left by those who have gone before. So what we're doing today, what Dr. Wu is doing in the labs and all of you, is all based on what people did before you. And that's very important. And anyone who studied history of medicine to that extent must realize the importance of this precaution. I showed this slide before. This was the last paper that he wrote on the Novoco, and he detailed the amount of animal experiments they had done. So look at it. So he's done 75 bovine experiments on the VAD itself, 129 in sheep, 66 in dogs for the skin transformer, and then he subsequently did like another 20. This is like almost 300 operations that Oyer did just to do one operation in man in 1984, and just for all of what we're doing now. And it puts in perspectives and allows us to understand and appreciate the efforts that go into what we're doing now. And then he goes on to say that since history is forever repeating itself, it's manifestly part of wisdom to make it the object of our closest study that we may profit by its lessons, both of the successes and of the failures. For what others have done or failed to do should point the way to their successes. So like when I told you about that study where they looked at Novoco device and they used the 2-week outcomes to make projections as to whether the device is easy to expand or embolize, we make the same mistake. We do the TAVR studies and we make conclusions within 1 year. There's a device called the Bivacor being studied now, total heart. They're taking them out in 2 weeks and reporting that the device works. We're making the same mistakes again. And they said there's the same uncertain part of human progress. It all happens. Now it's a sudden leap forward, then it's a halt, then it's attempts to surmount or find a way up around an obstacle, and then we find a way around the obstacle, then there's a hitter, there's all this moving, and sometimes we're moving backwards, moving forwards. And he says that a study of the history will teach us, at least to give us hints as to how we can make these leaps and avoid that to and fro and surmount the barriers as we see them. And the final thing he says is that, and this was written in 120 years ago, he says the fact is that we of this age are too carried away with the rage of novelty. Nothing is esteemed of consequence but that which contains something new. But in catching at the new, how often we risk losing that which is old and often better. So we want to do like a robotic, thyroidectomy, forgetting that it might actually be better to just cut the neck and take the thyroid out. But because it's new, we always feel it's better. Haste is stamped on everything. And this is particularly true of Americans. I'm not American, I didn't write this, so you can't blame me. We scarcely attain to one point, and this was in 1904. We can't scarcely attain to one point of the vantage when without rest we rush on to the next. We just want to go to the next thing, to the next thing, to the next thing. We seem to be drifting more and more into mere machines, mere worshippers of physical sciences. And that's what we're becoming, more machines and less doctors. So to summarize, 6 points which Cordell said, why we study history. It teaches us what and how to investigate, and I hope today you've got some idea of something. It's the best antidote we know against egotism, error, and despondency. So, like, if you notice, none of these papers ever had Shumway as the first author. Not one of them. Like, I barely mentioned his name. He was like a bystander if you look at the history. And then if you look, for example, and you see that they were doing this antegrade cerebral perfusion in 1970, no one talked about it. Then when you go and do your case tomorrow, and you say, well, I did this type A and I did the arch and I was out of the OR in 3 hours, you feel big about yourself. This puts in perspective because they were doing that 30 years ago, 50 years ago with nothing like the resources and knowledge that you have today. So it's an antidote against surgical egos. It increases our knowledge, it gratifies natural and laudable curiosity and broadens our view and strengthens judgment, that's obvious. It's a rich mind from which may be brought to light many neglected or overlooked discoveries of value. That's important. There's a French philosopher who said that there's nothing we do in modern medicine that you can't find the seeds in medicine of the past. We always have this thing, you say, well, I was the first person, you know, you write it, all these manuscripts, I was the first in the world to do this operation through this, you know, through the rectum and take out the gallbladder or whatever. You'll find out that somebody 500 years ago talked about that concept and that you were not the first. And then the fifth is it stimulates high ideals, which we poor mortals need to have before us. So like, I will never be like Craig Miller or Shumway or Oyer, but, you know, it does stimulate us and it helps us cherish our best traditions. And finally, it's a fulfillment of a duty, that of cherishing the memories, virtues, the achievements of a class which has benefited the world as no other has, and which we may feel proud that we were members. And I'll tell Dr. Miller and Oyer, if he was here, that, you know, you were that class and we're proud to be members of that class. Thank you very much for your attention.